Good morning to everybody here in the conference hall and those who are following us online. I'm glad to actually invite you to today's conference, which we have actually headed like AI in clinical diagnostics, from innovation to implementation. And the reason why we started this process to plan this conference was actually one news from last December that we have like around 1,000 AI-based medical device applications which have registered either by FDA or under MDR, but only a fraction. Those times the estimate was like 2 to 4% has been actually implemented. Now the question is, what is implementation? This is sort of ambiguous. And I tested this morning ChatGPT. And the ChatGPT is saying that I used implementation to mean used in routine patient care at one or more clinical sites, beyond a small feasibility pilot. If you define it as implementation as installed at more than 50 sites, the numbers drop sharply. What the GPT estimates today was that there is more than 1,100 applications which are registered under 510K in FDA, and some hundreds, like 200 to 300 under MDR. And the implementation rate is between 20 to 40%, as it's according to this definition what ChatGPT used. At the same time, when it comes to radiology, then the numbers are substantially higher, like 40 to 70%. And some surveys say that at least 45 to 50% of service providers has responded, at least in radiology, that they have been using or are using some AI applications. So the situation is maybe not as bad as it seemed to be last year. But of course, it's a dynamic field, and I think Thomas will give the latest updates. So I'm happy to introduce you Thomas, who will actually give the a keynote on CAIDX project, which Tartu Biotechnology Park has been partnering for the last 3 years, which was actually, I think, very ambitious, but sort of very useful exercise, which is actually directed to support the implementation and successful implementation of the new tools. So, ladies and gentlemen, please, I give floor to Thomas, and I hope that will be a successful and interesting day.
Thank you so much. So, a very warm welcome also from my side. It's nice to see so many at the morning here in the audience. As Janos introduced, we have been working on this project for almost 3 years now, CAIDX, Clinical AI-Based Diagnostics, that I will present today. And as he also mentioned, the focus is on implementation. So our main question in this project was, how can we get from the development into the day-to-day care? And we have focused on 2 main entry roads. Actually, in one scenario, I call it hospital-driven, where you have an in-house development, and like researchers together with informaticians, they create something, and it might work in their clinic, but to bring it to other hospitals, they need to certify the system, and that is traditionally not the work of hospital people. You need a company to collaborate to make it a certified product. The second scenario is company-driven. So a startup has developed an interesting algorithm, but at one point they need to clinically verify this, so they need a collaboration with the clinic. So if we look at the numbers, if you look, for instance, just to get an idea, I used to look in PubMed for artificial intelligence, the publications with artificial intelligence in the title. You see really a sharp rise there. 2016, there were 53 papers. Now you have nearly 4,000 in the last year, and altogether it's nearly 30,000. But what of this research really ends up, for instance, in a certified product? In Europe, we do not have the official register, but there is, at least for radiology, you have the Health AI register, and as of 21st of August, there were 265 products registered there only in radiology. In the US, there is a little bit more. In July, it was 1,247 entries. So these were the products registered in that database. But still, the question is, what of this, how is the implementation rate? We have no figures of this. What is really used in the clinics? Yeah, so to start with this, this was after, let's say, maybe 1.5 years of work in our project. We came up with this model, and you see it's quite complex. And the idea was, how can we create a framework that supports project managers that have the task to implement AI from the idea until the clinical use in day-to-day practice. And of course, as I showed in the first slide, you have different entry routes, so it's not like you start here and you end up there. You can see it more like a dynamic framework where you also can enter at different stages. However, we try to organize this a little bit according to the technology readiness levels. And we somehow divided it into 6 phases. But you also have like several tracks that are somehow spanning the whole life cycle. Like the clinical and technical development, of course, we have regulatory requirements to follow. And over all the process, you have also a kind of commercial evaluation, because it's also very important to have in mind how you are going to make money with your idea to have a successful project in the end. So after 2 more years of work, we came up with this model that we also now published also. It's the same idea, of course, but we just put on some meaningful phase declarations, like from idea over concept, development, then validation, launch and deployment. I think it's similar to many other frameworks for implementation that you can find. As I said, the process is not linear. That's why we also came up with this illustration here, that the process is like in a cycle. And most importantly, you have this post-market surveillance that you, of course, have for every medical product, but especially in AI, you have constantly to monitor the performance of the algorithm. And initially, of course, or AI is meant to learn, but currently that is not allowed. If a product is certified, then it is freezed. But nevertheless, you have to monitor the whole thing so that it not gets maybe worse. So, as I said, we have now published the results of our project. You can find it here under clinicalai.eu, and this is just a snapshot from the clinical AI pathway. I will not go through all of this. You can do it yourself if you just go to this website. There you have all the several stages, and you can dig into it, and you will find several tasks that are recommended to do in this phase. So that's the... Then we have also worked on what we call the CAIDX toolbox. So we have some information for needs identification that we called the game plan. Then we have a report on secure data. Then we have an implementation and change management guide. And we also have some links to external tools. So this is just a snapshot of this game plan. And the main idea behind this was that in the beginning of a project or a project idea, we think it's very important to be clear which way to follow in the development, because sometimes there might be already something on the market, but you don't know. So it's really important to have to do a good market research, whether there is anything that fulfills your needs, and the most important is, of course, to specify the clinical need very precise. And then maybe you have to choose either can you do it in-house, an in-house development, or would it maybe be better to partner with someone? Or if I said if there is already anything on the market, then you can, of course, buy this. The next thing is secure data. We have published a report about this. The intention was to provide something for clinicians or people that are not so familiar with this topic to give them an introduction. You also find this on our toolbox. And yeah, this is one topic I have also quite much worked on. It's the topic of change management. So why do we need change management? And I have tried to illustrate this, that the things you see, like, or that you work in project management, like cost, quality, and time, this is actually only the top of the iceberg. But many things are somehow hidden. For instance, the acceptance of the users, or the behavior, the attitude towards what you are doing. And often this is the biggest part in the project, so that you can really get everyone involved on board. And we have come up with a model. There are many change management models. We just picked out this one from Kotter and adapted this a little bit to AI. And we recommend to have a strategy if you go on such a project, that you at least, it's not like a recipe that you can just go through and follow it, but it's meant to be an inspiration and like a strategy or a guide that you can use to organize the implementation process. Then, of course, we are not the only ones working on this topic, and we have come up with a list of useful resources that we are providing also on our internet website. where you find a lot of interesting stuff around ethics. There are a lot of ethics frameworks for AI. There are a lot of evaluation frameworks that you can use. AI risk management, information about legal information, the glossary. So that was intended to give an overview of what is also there. Finally, this is the website. If you go to it, you will come there, and then we have this AI pathway guide, the secure data implementation. Then we also have some small videos and the read also section. So now I would like to give you some food for thought for our next sessions, actually. And we have particularly one session on platforms and one that addresses also procurement. And I also picked this nice publication where it says they have researched 173 commercially available products and try to find out what evidence do they provide. And the good message is it improved over the last years. However, around 25% only have higher level evidence. So most even of the certified products seem not to have scientific evidence behind it. And that's a good, and our message is that for acceptance by the medical community, it's very important to have this scientific evidence. There's also another small idea that you also, yesterday we learned that there are deployers and providers. And if you deploy the technology, according to the EU AI Act, you also have to take care about all the regulations behind it. And this is a nice framework actually from James Kavanagh, where he put all the ISO specifications and the EU AI Act and the NIST RMF framework together and looked for similarities and came up with a nice framework. And it's really important also to look into the AI governance aspect. Because if you just have one singular algorithm, okay, fine. But in a hospital, you easily end up with hundreds of algorithms and hundreds of tools. And it easily gets complicated, I guess, to manage all the things and to have really everything under control. And as we also heard yesterday, for instance, AI literacy, you have to make sure that everyone in your organization has the right level of AI literacy. And that's why I also wanted to pick this out here. Now to platforms. Health AI Register has a nice overview of platform providers. And as you can see, for instance, Bayer has 35 applications, or DeepSea from Germany, they provide 68, GE Healthcare 29. And so our thinking was, because we provided a framework from developing one algorithm, one product, from idea to market entry. But then, of course, even if you have a certified product, the hospital has to procure your product. So actually, if you just see this 100 or 265 radiology products, if they have to be procured one by one, that's also a big amount of work. So we think that probably in the future there will maybe be these platforms coming up. There's another one I just found on the internet, Care Syntax. And in Septo, they have also the idea of bringing several algorithms together on one platform. And here's an example from Germany. It's actually a teleradiology network. that is running for I don't know how many years already. But now they have come up with the idea of plugging in also AI algorithms on this platform. It's CAIDX. And they use the DICOM email standard to make this. And they have over 100,000 transmissions per month. And I think currently they have something like 700 clinics connected to this. And with this system, they can now, if they want to have a kind of AI service, they can just click on and have one of these, I think now, something like, I don't know, I found 30, but maybe they have even more now, like 70, can use these algorithms in the network. And of course, for an AI provider, it's very interesting that you have easily 700 clinics potentially using your algorithm. Then I also wanted to mention, because to fuel our discussion in the platform session later on, that there are also open source opportunities. And here's an example from the Netherlands. Sage AI, they want to build an open platform for LLMs in the medical domain. So this was just some inspirational thoughts for the further discussion. Here is our project website. We are also on LinkedIn, and you're very welcome to follow us there. The project partners, there has been something going wrong with the picture. Anyway, thank you so much for listening, and I hope we have a fruitful discussion over the day and that you enjoy the day and the discussion here. Thanks.
Thank you very much, Thomas. This was really good introduction to the day and gives a good basis. Now I'm happy to actually introduce to the next session, and my good old friend Lars will take over for next hour and a half. Thank you.
Thank you very much, dear audience, and thank you, Thomas, for a good view of what you have been doing there. And I really enjoy being here in Estonia. We've been here the whole week, and it's amazing to see how much you have achieved. And now we're going to talk about the artificial intelligence, something that doesn't exist. Isn't that fascinating? And we believe that it will solve all our problems. We will have a panel, but first we will have a keynote from my dear old friend Nasim Bergman of Farrokhina. Farrokhina. Yeah. As you can see, she is pointing out a lot of things, how things should be done. No, honestly, she has been a mentor for me to understand it from a clinical perspective, trying to join forces with technology and still be a part of the human, part of being a human, so to speak. So Nasim has a great experience as a medical doctor. She has been starting up a lot of innovations. She has been leading a lot of big projects and so on. So I'm really happy to hear your thoughts about the future. And I think the theme of your presentation was AI as a collegial advisor, the physician's role in the digital decision room. So please join me on stage and learn us something new.
He's too kind, isn't he? He's my mentor. Or maybe we learn from each other. Thank you. Good morning, everybody. Let me start by thanking our organizing committee. for this amazing week of gaining knowledge, making new friends and contacts, and all these excellent lectures. I've been learning a lot. Thank you. And yesterday evening, we were on a tour across this beautiful city of Tartu, and I found so many heartwarming similarities to my alma mater, Uppsala University, where I studied medicine. And I also learned that 1991 was the year of Estonian independence from the Soviet Union, 1991. And then I remembered a year prior to that, back in 1990, that was the year where my journey, transformation journey across the Nordic, European and global health ecosystem started. I was 18 and came to Sweden without knowing Swedish or anything about the European culture. That was a very exciting meeting with everything I gained. You can imagine I was a woman from the Islamic Republic of Tehran, Iran. So what I gained was a lot of freedoms, and that made me excited. And also feeling some kind of gratefulness because I was given a second chance, being a survival of a revolution and a war. And that sense of gratefulness is what I carry every day, regardless the role I have, professional or in a personal meaning. And you could ask my teenagers, because I do remind them a lot. They were born in Sweden, of course. I'm a medical doctor. I earned a PhD. My specialty is internal medicine, meaning since mid-90s, I've been working with cardiovascular diseases, both as a research project, but also in clinical practice. As an internist, we do a lot of on-call duty. And I remember early on during my career, I was very fascinated by the detective part of the role, being a physician, studying the diagnosis. But then, when I practiced more, I learned the beauty is to gain the trust of my patients, another human being, to actually follow my advice. Because otherwise, they could have ended up at the emergency department again soon with yet another myocardial infarction or stroke. And with that, I also felt a lot of frustration not being able to fully communicate with my patients because I wanted to prevent the next event and the next. I hope these images resonate with you. The first one I borrowed from WHO. This is their program on digital health. What speaks to me is that WHO puts a lot of emphasis on using these new tools to bring more health equity. They are related to those 30 sustainable goals of future development in all different sectors. And that speaks to me because I remember how it was in Iran. I was 18, and I also know that in Sweden we have a lot of rural areas. And I also know throughout my work at Microsoft, I'm part of Microsoft Global Healthcare Advisors, experts, and work in Europe, Middle East, and Africa. I know that we have a lot of inequities when it comes to health outcomes in different countries, and also within the borders of a country. So with that said, to me, using these tools to squeeze these gaps. Of course it's important. It's an ethical issue. Being an internist, of course, I monitor people's blood works, blood pressure, etc. The image in the middle, as you can see, it's an elderly citizen, and she's measuring her blood pressure. And these kind of devices are also getting cheaper and cheaper. My own husband, he bought himself. He has a bunch of different gadgets. The Oura ring, he has the device monitoring blood pressure, etc. That's also some kind of empowering or democratization asset or tool into the hands of our patients, individuals, citizens. I'm a part of Digital Care Research. This is a national Swedish initiative bringing scientific researchers together from different parts of the country. And I know that many of my colleagues on that network are studying that kind of initiatives. Still, as you pointed out, maybe as pilots or POCs, but they are getting bigger because, and I'm gonna touch upon it, it's a journey because we learn for every step along the way. So everything isn't perfect from day one, but we need to keep trying and to keep bringing back the knowledge into these iterations or pilots to make them better. And then, of course, everything around omics, genomics, proteomics, etc. Those large data sets that we've been also seeing here in Estonia. So I don't want to preach to the choirs, you know this. So handling all this kind of data, of course, this is also one side or benefit to the whole digitalization or AI journey. So in summary, I've been with Microsoft for 3.5 years. It's quite a humbling journey. You see, when you are part of a team and you are born in Iran, and you have someone from Israel, another one from Saudi Arabia, and a couple of Europeans on your team, and there is the war, it's humbling. How you actually listen to each other, to actually listen and be there for each other, and set the politics aside and searching for those values, true values. So for us, technology is the applications to solve actual problems. That's why it's important to be a practitioner. I also changed doctors to healthcare professionals because I truly believe that we need each other's unique skill sets to bring all the healthcare professionals together on this journey. Can you see what this is? This is an image from an emergency department. This is Södersjukhuset, Stockholm Southern County Hospital. I managed this ED for 6 years. And here I want to share my key learnings from these 6 years. What also was part of why I one day quit and accelerated my learning journey as part of the private sector. So it was beyond just being curious. The link leads you to, this is the PhD thesis defended by my PhD student. I had the pleasure of being her supervisor, Jenny Liu. She's also a GP and emergency physician, so double specialties. And she was the leader of our whole change project across the whole emergency department. When I came to Södersjukhuset, I reported directly to the CEO, the director of the hospital. And by the way, so you can compare, I learned when we visited the Tartu University Hospital that the attendances or arrivals to the emergency department was around 37,000 a year. At Södersjukhuset, we handled 110, so around 3 times bigger. So that's the volume of the patient we had to handle. And she said, okay, Nasim, you know the waiting times are way too long, and the staff they are unhappy, and your task is to make it work. And please promise, stay, because we need that. This kind of change project needs continuity. So I promised her to stay, and that's why I gained a lot of gray hair, and I stayed for 6 years. And then we created or produced this PhD thesis, and during that time there were also a lot of political changes in Region Stockholm. This is located in Region Stockholm, so politicians made organizational changes and changes to the university hospital, emergency of Karolinska, etc. But still, we had the people to take care of, the patients and of course the personnel. When we started this transformation journey, because transformations are new to us, to AI, of course we are transforming all the time. Preventable, I come back a bit. Preventable emergency visits and hospitalizations are far too many. Could you take a guess? So we did a data-driven work, looked through every admission to this emergency department, all these, every one of 110,000. So if you could take a guess, what portion of this could have been avoided? Please, just guessing. 20%. Higher? 50. Kind of every other patient, every other. And that was the work done with different specialties. So emergency physicians, cardiologists, orthopedic surgeons, internal medicine surgeons, etc. So all together. So every other patient. And those were divided into 2 different categories. One was because of lack of accessibility to primary care. That's a huge problem. And the other was, okay, people with different kind of chronic conditions, being alone handling them. And that I knew from being an internist. And that's why the whole idea around home monitoring speaks to me, because it makes sense. Let's support people where they are to avoid them to end up in the ED. Because, you know, we want to develop healthcare from being sicker to more preventative. So that was what we found. But also, using data, for example, I learned, okay, I had 85 rows of schedule, so 85 people, 24 hours to staff one day on an ED, 85. Different specialties, different kind of nurses, different kind of nurse assistants, etc. Quite complicated. Doing the triage, the sorting out, and then all the processes across this emergency department. And we learned that if we use data better, for example, we knew that the peak of arrival to the ED is around noon. So in between noon and 2, 3 in the afternoon. Okay, so let people start some, say, 1/2 an hour or 1 hour ahead to avoid this peak of getting in crowded ED. So that's just one example. And of course, AI is a powerful enabler. If you can replace one human being with algorithm to easily do the analytics, of course, that saves you time. And then, speaking of adopting new technologies, we learned in order to change the way of working from the way we did when we started the project to actually address these long waiting times and, for example, avoiding for these people to repeating themselves, the patient story for different professionals. We learned that in order to be able to change the whole workflow, we needed to break it down in more manageable pilots. And every pilot was 1 week. So again, if you could take a guess on how many this kind of pilots do you think we did from day one till we changed the whole way of working into team-based? So how many pilots do you think we carry out?
It can be many, it can be less, 5.
5 pilots? Much higher? 10. Much higher? Yeah. Closer to, 85. So you see, and that was throughout 2 years. And raise up your hands, all of you that are within healthcare. Okay. Yes, kind of. It's me too, kind of. So you can imagine, and all the pilots were concentrated during, say, we excluded, of course, during Christmas and New Year's and summertime. So we had those. So this took 85 weeks throughout 2 years. 2 years of piloting. And that's what I always remind everybody only doing business and showing me those fancy numbers. Okay, this is too fast. Don't work. Sorry to break the bad news, but too fast. You're handling people. But I hope you see the strength into this third finding is to actually get people involved. And in every cohort of people, find those early adopters, energetic, those who they see the vision, they see the goal, and they are kind of want to start running. Capture them and make them be the leaders of the change and get people involved. That works. And give it time. It's the same with algorithms. With that said, we worked together for 6 years, and this was between 2012 and 2018. And during that time, you know, Sweden is strong when it comes to entrepreneurship and engineering, and I'm so proud. And also the rest of the Nordics, and Estonia is part of that. We've been fostering many unicorns, global unicorns. I realized my staff, they are frustrated not having good enough tools to take care of their daily work. But I could use apps communicating with authorities, did a lot of stuff that could unburden me as a mom of 2 young kids and managing this ED. And I tried to communicate with the IT department, and it was kind of, we are talking totally different languages. We don't understand each other. So somehow, my curiosity and frustration got so strong that one day I quit to learn more about these other silos in order to bring back the solutions into healthcare. That's why I ended up on this, say, private or being part of the health tech industry. You remember, this is, okay, we know that we have aging populations and increased health care needs. Yeah, one of our challenges. We know that rapidly emerging technologies produces a lot of data, and human brain, even though we can train our brains, not that good. Takes time to digest and run analytics on this. And then, this is the sad part, of course, all the geopolitical tensions, and that's the threat, of course. And then my favorite parts, because here we do have challenges, but here we also have all the possibilities. Here we have the power. This is the manpower, people power. And of course, we can get these bubbles or communities connected. This is the healthcare professionals. And I know there is shortages, there is really poor user-friendly tools, and a lot of lack of interoperability. So huge, huge problem, a lot of pressure upon healthcare professionals, but we have also an accelerated adoption in everyday life across different sectors. And these learnings and these new skills are actual assets. So if we do it better to get these bubbles better connected, then we could do so much more. This remember? By the way, do you know why those first cars were invented in the US by Ford in New York? Do you know? 100 years ago? Was it because we wanted to have fancy stuff instead of horses? Do you know why? Too much horse shit. Yes. It's true. It was a huge problem. So you see, from a problem to actually having inventions, and we human beings, we are really good at innovation. What's special for healthcare is that a lot of ethics are involved. But we're going to discuss it further. And this, you remember, people power, and this is Lars, back in the old days. No, I'm just joking. One of your friends, maybe. And then we have AI. Okay, let me walk you through this. This is so exciting. Have you seen this before? So I thought, and I can share these slides, and if you can study this further. So the source is the Madison project from Groningen University in the Netherlands. Okay, they've been looking through a lot of data. So the x-axis is the easiest one. This is time. You see 1100s, 12, etc. So this is time. It's kind of a historical overview. And then the y-axis is really interesting here. This is, note that this is logarithmic scale because 0, 1, 10, 100, okay? And what you find here is global GDP. And then this GK, or international dollars, is an international hypothetical currency just to be able to compare different economies, okay? With that said, look at this. Printing press happens, 1400, and you see this is also the GDP growth multiplier per century. Here we have 0.4. Yeah, quite slow process. And then printing press. This is the first step towards democratization, access to knowledge. And then you have later on, here's things starting to happen, steam engines. This is the first industrial revolution 100 years ago, okay? And you see 2 times faster. Here is happening electricity, assembly lines, löpande band in Swedish, here. And then you have fertilizers, transistors. This is modern time, PCs, internet, smartphones, cloud, and then AI. And you see from 1 to 2 to 4 to 20. So now the pace is really fast. And what is this? Transformer, yeah, I learned it because I have kids. They played with the Transformers. And the Transformer, quite scary, but also quite powerful. So generative pre-trained transformers, GPT, ChatGPT. So these are large language models in desperate need to be controlled. Of course, that's why we need authorities. If we circle back to the whole curve of, okay, technological progress and prosperity, etc., we connect that to the pace of change. You see, usually or normally we have that kind of linear change. And technology is always the fastest, the change in technology. Then we have businesses, They run the step after. And then public policy, a bit slower, the next step. But as long as the pace of change is linear, it's quite easy to handle. That's what we are used to. But then the transformers happen. And you see, what happens is, right now we are facing this exponential change. And the adaptation zone is increasing for every minute. And that's challenging, because we are not equipped, really. It takes time for policymakers. And this is also if you imagine, this is a combination of contradictory powers, a lot of power to add value, but also a lot of risks. So you need to navigate in this somehow. And that's why I believe back to the power of the people, but also, of course, healthcare professionals, because you need to have a solid root in both knowledge, understanding, and insights, but also ethics. This is the world of today, isn't it? The world is diverse, and we communicate both here, but also online in different kind of social media platforms. These augmented reality or VR glasses are also used in healthcare settings. For example, during the pandemic in the emergency department in Helsingborg, this is in Skåne, southern Sweden, we used these glasses for the younger doctors being on bedside with the patient, communicating with the senior physician, supporting the younger one to handle this patient in their home. Because you remember the pandemic, we knew very little about this new virus, and we knew that it was harmful, and we also knew that so the age is one risk factor. So we had our younger physicians on the front line, and then the older one, okay, backing up. Then you can use these augmented reality glasses to actually see the patient in real time. And then home monitoring, digital or consultations, and nowadays ChatGPT or whatever. ChatGPT is only one example. There are so many different that kind of LLMs, chatbots. So that's only one example. And then, of course, our vision to develop healthcare to be more patient or individual-centered care. And you can see all different parts of the life, because everything isn't healthcare. A lot is also support during self-care, of course. And also in a collaboration across, together with different kind of healthcare professionals to support this individual. And not only healthcare professional, maybe a personal trainer or maybe a nutritionist to support somebody during this journey of primary or secondary prevention. But what's happening, and you remember the curve I showed you, it was the first industrial revolution, and historians say we are in the midst of the fourth industrial revolution. And having in mind that very challenging adaptation zone, what we are facing is, okay, this is the strong upside because this is a democratization of access to data, information, and technologies. Nowadays, I visited one of my physician friends last week. She is a GP. She's fantastic, handling her own practice, like many other GPs. And it took her only 2 weeks to get into GitHub, purchase a couple of licenses and a couple of co-pilot licenses. And she, being a physician without being knowledgeable in coding, she's not an engineer, it took her 2 weeks to build a whole tool for triage. and getting that connected to her patients when they reach out to her nurses and doctors to be put into the right, say, process. And she said she did that because they noticed in her practice that depending on which one of the nurses or doctors who first met this patient, they actually chose different ways. She wanted to bring in more standardization and a higher level of patient safety or equity. But this is, of course, challenging because even though sharing is caring, and I believe you can imagine the idea of sharing your power or your knowledge with somebody else is quite beautiful, but it's also challenging. Because as a physician, okay, I'm your guide and I can share the knowledge, but if you go and consultate ChatGPT and do something, who carries the responsibility? So it's about accountability and responsibility. So how can we find this new role as physicians or other healthcare professionals in this very challenging setting, which also presents a lot of possibilities? Do you recognize this one? Nothing in life is to be feared. It is only to be understood. And by the way, if you are really sincere with yourself, I can start. Of course I feel fear. Beata, do you know who said this? Take a guess, it was a Polish scientist. Anyone? Marie Curie. And she is, of course, amazing, one of a kind, 2 Nobel Prizes. But you remember her journey? She got cancer because she was so fearless using that new findings into X-ray. So those first ever how to examine, of course, origin of everything around radiology and radiotherapy. She was fearless. So we can learn, okay, I feel fear too, but it's important, not least as, and I could say, because I know that we have a diverse backgrounds here, you are knowledgeable in so many different fields, and I believe having those transformers in mind, remember, the fear is about get yourselves educated and be an active part of this change, because that's the only way. We need to understand and control in all different roles. And one such for healthcare professionals is, of course, we have always the purpose of we want to help people. So these tools, technologies, they don't have a value in the sake of the technology or AI. It's not a hype. We will use it to save more lives or help other people. And of course, we need to communicate our knowledge and wave it into workflows or decision-making processes or product development in different ways. And of course, we need to be an active part of all the risk mitigation processes. And a couple of examples. These are, many of you are familiar already with these. These are components around responsible AI published by WHO. And you see an algorithm or AI implemented into clinical care flows need to meet these mandatory aspects. Privacy, security, inclusiveness, accountability, transparency, fairness, reliability, and safety. And of course, these we need to wave into the safety bias, trust value into every part of building tools, processes, trainings, etc. And all this means human in the loop, always human in the loop, across every step of the process, including when you pilot, build your POC, or make it used by healthcare professionals to gain more information and do that plan, do, study, act cycle to refine it. And there are already 2 trustworthy responsible AI network collaborations, one in the US. This is driven by the Duke University Hospital. And in Europe is right now, the chair is Professor Michel van Genderen. He is at Erasmus Medical Center, Erasmus Medical University. And the vice chair is a Swedish professor, Stefan Jovinge, and he is at Skåne University Hospital. So you can find the papers and learn more. And also a reminder that regardless what we use AI or algorithms for, this can never be replaced by any AI. But I wanted also to display the diversity we need. Not only, I can relate to that as a physician. Okay, I know of a lot of conditions from Middle East because I was born there, raised, but then I gained my training, clinical training in Sweden. And many times, if I meet a patient with some rare disease from another part of the world, my brain isn't. So I have a biased brain because I haven't trained to see and recognize. Here, I can combine my knowledge and insight with an AI to find rare diseases, for example. But this is also says why it's important when it comes to your data set, where you build your algorithm, that it's inclusive. And I know that we have a lot of this kind of visions for the future, the seamless experience, not least when business people express it could be so fancy. But behind this, I know that there is a lot of hard work. And yesterday when I listened to the panel on European health data space and interoperability, primary, secondary use, 10 years till we are there. But still, what I wanted to say here is also that public-private partnerships are very important, because in order to support people in their homes, they need actual gadgets for monitoring themselves. And that's provided by, hardware companies. Or those algorithms, those we create together with companies that develop hardware or software. And we need the regulators to set boundaries to avoid the misusage. And of course, there is also a responsibility with authorities when it comes to regulations, reimbursement models, etc., to avoid any kind of misusage. So a very close public-private partnerships. Any Harry Potter fans here? Ish, same for me. But what is impressive, isn't it? How can somebody come up with all of this? That amazes me. The human fantasy and creativity. And that's also a reminder, no AI will ever replace that. This is the power of human beings. And it's also the power of every meeting in between myself as a healthcare professional and another individual. But because that connection, those sparks in the brain, no AI can ever replace it. But I can use a machine in order to be focused in that clinical consultation. For example, I believe you know all these new inventions on different devices. It's a combination of hardware and software to actually transcribe what's happening in between a physician or a nurse and a patient. And we know that the focus being in that moment is much, much greater. And something else is taking care of the documentation. That's good. So just wrapping up, this you recognize, having the courage, because innovation per se, we don't have answer to all the questions, but we need to learn one step at a time. So the iteration and having the grit, and please do it together, of course. But the hardest part, I believe, this is the leadership. This is the absolute hardest part. And here, this is for both us as individuals, but also managing if it's departments, countries, institutions, etc. If you want to study more, Eric Topol, he was, I remember I read one of his books 15 years ago, The Patient Will See You Now. And that made a strong impression on me. That was my first step. Yeah, you're right. And then the whole patient advocacy organizations, very strong. And Eric Topol, he is a cardiologist. He talks about how we can use technology to make medicine human again. Otherwise, Hacking Healthcare, I know, provocative title, but a lot about the tension in the ecosystem and why, in which ways we need each other. This is a lot of early publications on generative AI in healthcare. If you just visit PubMed and search, there are thousands and thousands of studies on generative AI in healthcare, different subjects. And this is a book written in Swedish. I wrote a chapter. I just want to stop here. This speaks to me too. The secret to change is to focus all your energy, not to fight the old, but to build the new. Very humbling also. Remember that we are facing a journey, a process, and one step at a time. And actually listen to each other and include different perspectives. Thank you.
Thank you so much. It's hard to have a panel after your wisdom. So I will give you a hug. Wasn't this amazingly to see how we can combine the things here? So please take a seat here. We will have a panel and discuss some of parts of this, and I'm happy to invite some distinguished brains into this panel. So first of all, Mihkel Miidla, that is coming up here. I bring you up all at once, and then we will discuss. I also have the Madeleine Blusi coming up here, and Maeden, Teklay, Zeray. Please. I had invited some more guys from Estonia, but from familiar reason they couldn't attend today. So for me it means also that it seems that the human part of life is more important, so I like that. But for that I would also like to invite Thomas to be on the stage in this panel. So please come up here. Did you have the clicker?
Yeah, I left it here on the table, sorry.
Let's see if something's happening here. I started with a white image because it's like the cloud. You don't see anything. And one of the things I always think about is if you're going to look to the future, you have to look back. So as I'm an old man, I like other old men, and I have those two guys. Do you recognize them? Plato and Aristotle. And they have in many ways formed our lives, so to speak. And I like Plato, you know, he's the guy that is pointing upwards. Think what we can achieve. Think what the European health data space can actually give back to us. And then we have the more realistic guy, Aristotle, is pointing, hey, we have a real world also. So for me, it seems to be that life is about that movement. You know, you have an idea, you think it will be work, and you meet the reality. And sometimes I feel that today we are pointing too much upwards to the digitalization, the AI, the intelligence that doesn't really exist, and so on. And we are now focusing a little bit more on forward to the real world. So I used to say that we will see humans needs humans to become humans. Human needs humans to become humans. And I think this is something we see more and more. And as we heard from Nasim also, that we are talking about that from the healthcare professionals also, that we are here for another reasons. So this is a part of the school in Athens. And read about this image. It's fantastic to see how the painter was putting all things together. And in Sweden we have a saying, everyone is allowed to be a part of it. And that's something I think is important for us all to understand, that everyone has the possibility to be a part of it. We can't really say that it's only the IT people and the process there that will bring us the metrics that will give us the true life, or the doctors at the bedsides, or the nurses, or the young entrepreneurs, and so on. So this is quite interesting to start to think about how everyone can be a part of it. And I must say, I recognized one important thing that Nasim told about her private life. Her husband is using all the gadgets to do the measurement, even if he has a doctor in the house.
Doesn't listen to me.
No?
No.
You see? So that's really a part of life, that we are different here. So with that ahead, I hope we will have a good discussion here in the panel, and I would like to all of you in the panel use a couple of minutes to describe who you are. As you know, I like to have a part of all, as you can see. So when I started here, I invited my girls from Sweden, and I had the boys from Estonia, but now some of the boys left. As we usually do, we don't take our responsibilities. So, but I at least trusted my good old friend from Germany to be a part of that. So, please, Mihkel, could you tell us a little bit about your background and thoughts?
Yeah, sure. Good morning, everyone. And my name is Mihkel. I'm actually working as a lawyer in Sorainen law office here in Estonia. And my, let's say, primary specialization is data protection law. And at Sorainen, I'm leading our technology, media, and telecommunications sector group across the Baltic states. So we're present in Estonia, Latvia, and Lithuania. But I also have a technical background. I have a, let's say, engineering degree in digital transformation. And technology has always been close to my heart. And that's why let's say the specialization towards data. Contributing perhaps with some thoughts to this panel from a perspective of legal issues. So I think it's important. Just to remind that the topic for the panel was data, about data access. So from legal point of view, then I would like to emphasize the core tension here, which is on the one side, the need for innovation, the need to get easy access to data, to cut red tape, to enable all the nice things that we could have. And on the other side of the scale is a little something called fundamental rights and freedoms of individuals. And among others, most importantly, right to private life and right to data protection. So there's a outright collision there. And let's say in the clinical setting, in the healthcare sector, we are usually then also talking about health data, genetic data, which in terms of risk is perhaps categorized as something carrying the highest risk. If you have a data breach, you lose trust, and then the impact to the particular individuals is astronomical. could be astronomical. So that's why this innovation, which we all like, and which is happening, needs to be careful. And here the keywords are, of course, accountability, and what has happened recently, I mean, everything is not new about data protection, but what has happened recently is that we have had an explosion of regulations in the EU concerning this area, data, medical devices, access to health record. So a lot of change has happened, a lot is coming, and this has created kind of what I would call a regulatory multiverse, because they are, it used to be simple. You worked in one sector, you had one kind of law to guide you. Now you want to create a medical device, you have to look at a hefty compliance task in the beginning. This, of course, is kind of at one end of kind of hindering innovation, in my mind. But on the other hand, this is what the society right now expects. And you know, ultimately, if I draw some optimistic thoughts in this regulatory multiverse, I think that the perception of societies is changing a little. It's becoming more open to secondary use of health data for the greater benefit of the society. But this, of course, depends on what actually happens in a society. I can draw an analogy or parallel from, let's say, area of public security. So imagine if there has been some tragic event in society, some mass shooting or terrorist event, then everybody is saying that why didn't you prevent this? You had all the digital data, law enforcement, where were your eyes? Let's enable you to use all the pattern and facial recognition tools or whatever you need to prevent these sorts of events, and then the society is more open. And then on the other hand, years go past, and somebody learns that you know, the state has been spying on you without proper legal basis. We have a recent case. Those from Estonia know that the police has been taking a lot of photographs of vehicles and their numbers and passengers without proper legal basis. And then this created a kind of a huge uproar, rightfully so, in society. And then it was like it's a kind of a tug of war. But when it comes to health data, I think things are changing. Society is becoming more open to having people are open to having their health data being used for good causes. And countering the regulatory multiverse, I think to just wrap up with an optimistic tone, I think here the role of innovators and entrepreneurs cannot be understated, because innovators and entrepreneurs, they will drive the change anyway, and do continue to do so, even if you are faced with this seemingly high wall of regulations and requirements to be compliant. Yeah, I think I'll end here. Thanks.
Thank you, Michael. I really enjoyed to see a positive lawyer. Normally when I meet them, they say no.
Yes.
So, but it's obviously that we need to work closer together and earlier in all projects and so on. And it's important with those things. And as some of you know, that I'm a little bit of a semantic nerd. I think that words has a meaning. Okay? So I dislike sometimes that we talk about health data as a problem. Isn't it the sick data that is the problem? Because we post always how good we are on our health data, how much we have been running and all these things here. So I go on with my panel, and I would like to introduce a new good friend of mine, Maeden, that I met as a student, actually. And when I meet students, I used to talk to them, how nice to meet the future. And then suddenly I realize, oh my God, I'm closer to the future than they are. So we seem to be hunting the future all the time. And the problems for the one after me is that they have to fix all my things that I have done wrong. So, Maeden, you have been looking into some parts of how we actually use or could use AI. You wrote your thesis about that, or your master?
Yes.
Did you have any image?
Yes, but we could take that later also.
Yeah, we can see if it comes up here.
That's mine.
Nope, that's
I think it's in the end. Oh,
after the coffee break.
Yeah,
No.
that's,
Yeah, but you took something. It doesn't work.
that's fine. So hi, my name is Maeden Teklay, and I'm working at Byggr.ai, which is a company developing deterministic AI for software development. So when I met Lars, we were looking into, I have a background in informatics, and I was looking into the scaling and adoption of AI solutions in healthcare. And we saw in our country in Sweden that there's a lot of pilots happening, but the value is not getting exploited. So it's just reinvention of the wheel over and over again. And this is what I now bring to the table, which is this hybrid intelligence. Like Nasim was talking about, AI is there to augment the humans and the healthcare professionals. And we introduced a lot about the LLMs and their transformative power in making sense of data. Like we're talking about data access, but it's not just access to data, but what we also do with that data. And we have to also follow a lot of regulations, as we had a lot of healthcare professionals here know it's heavily regulated, and we need to build compliance in health tech solutions from inception and not something that is an afterthought, which then becomes very cumbersome for us. So the hybrid intelligence that I'm talking about is the use of the humans, LLMs, and more deterministic approaches that give us more structure and follow rules so that when we have the data, we can process this and have a structure to it that makes it reproducible, because the input that we're getting, the data, should always have the same output at the end of the day, so we can scale it up on our different organizations in Sweden, for example, so we're not always reinventing the wheel. But at the end of the day, the humans are always important, like you guys here. They always need to be in the loop because they're giving us context and signing off at the end. So that's just a short summary. I'm happy to be here. Thank you for inviting me.
Thank you. So now you listen to the future. I have an old friend on this panel also, Madeleine Blusi from Umeå, the northern part of Sweden, where I come from also, so we can speak with each other and understand each other. Mm-hmm. I see if you find your images.
Yeah.
But Madeleine, you have been around and thinking a lot about the perspective of AI. Okay.
Okay.
So please.
Yes, I am. I put the slide together to show the rural perspectives of northern Sweden. I work with as a nurse in Region Västerbotten, which is we're located in half of Sweden. We serve half of the geographic area of Sweden, actually, but only 10% of Sweden's population live there. And motivation has been a topic coming up during the days here in Estonia, and in our region, I would like to say there is a high level of motivation. for technology development and AI in healthcare, and it is because it is necessary, not because we fear that technology will replace humans. It's because we don't have enough humans. So the big alternative is actually, should we have healthcare or should we not have healthcare? And a way to enable having healthcare is using technology. The alternative is zero. It is a very particular situation, because when we take part in the research community and when we listen to many things and ideas that come up, in theory, anything could be applied in our region as well. But the thing is that rural regions with long distances, what works in urban areas doesn't necessarily work. And also, doing tests and pilots require, as you said, a lot of time. But if you consider involving some patients that may have 6 or 7 hour drive one way to go to the hospital for their chemotherapy or radiation therapy. I'm an oncology nurse, by the way, so cancer care is my specialty. It requires totally different solutions, and we're often, both our nurses and doctors are often excluded from tests and trials because it takes too much resources and it takes too much time to get it all together infrastructure-wise. And also I put, to illustrate a bit in the picture here, that when you drive along E4, which is a big European road, you pass and it's like, next McDonald's, 45 minutes. The second one, 2.5 hours. And the third one, the next one after that, is 4 hours away. And that kind of illustrates something people can relate to about the geographic distances we have. And of course, we have winter for usually at least 6 months. So traveling also is often in snow, smoke behind timber trucks. Some pros and cons regarding the health data. The pros is that we think that since there is a shortage of staff and everything is far away and resources are declining, for example, decision support system is a really good way to enhance the competence and decision making of nurses and doctors. Because when you don't have a colleague to ask, you can use the decision support systems. And also from a patient perspective, using personal data in AI features for empowering the individual and helping them with getting better health from their own data, I would say, are the two major things. Which brings equality, actually, because otherwise, when the option is no healthcare, equality becomes an issue. But when you can actually have healthcare, it's a great advantage. And a risk also is the risk of inequality, because if the data you use on a larger scale, and if the decision support models are created on data that does not have enough data from rural populations, then maybe the advice given is not proper for this population.
Good.
Yeah. Thank you.
So Nasim and Thomas doesn't get any more time in the spotlight. They've had their time there, so you will just be a part of the panel here. I would like to start to discuss a little bit about the theme here, data access. Because for me, data seems to be probably the most problematic word we are using. And we really doesn't grasp what it is. And we have so many perspectives on what data is. And I think that from a healthcare perspective, we say data is information. And therefore we are so scared to share them. But when you talk with data people, they love the data points. They like to bring out a part of it and compare it and so on. So from that point of view, I would like to ask you, Thomas, perhaps, do you see a problem with data access?
Good question. Yes, of course, there's a challenge. We heard yesterday and the days before that several people were claiming, yeah, we have no access to data. And we heard about the GDPR and all that stuff. Actually my big hope is also the European health data space that we talked about yesterday, and we also heard that it's a long road to go, but I think it's inevitable. I think it's really worth doing this, and in Germany we also have this situation that we have these silos. So we have a lot of data stored, but it's not accessible. At least not outside the hospital. So for one hospital, I think it works quite well. You can do research on this, but in many cases, and specifically now in AI, you just need more data. And so that's why I hope that we really get forward in this standardization and exchange.
Interesting, good. Do you have the data access you need as a nurse when you are on duty?
To treat my patients?
For the situation?
Yes, I would say I do, but it can be really hard to find sometimes, and it can take quite a long time to find it, which is something we discussed, that we know that the data is there and that it is available and we have access to it, but in a stressful day, it's many times when you would like to use it, you choose not to because you don't have the time to gather it or get into that situation.
I like that because it's time consuming to use data. And as professionals, we are trained to solve a situation. So we don't really have the effort or time to use the data. On the other hand, we see quite often that we are feeding the beast. Most of our doctors and nurses are in front of the terminal to put in data to something that we don't know what it should be used for. Michel, you talked about the risk of sharing data. And we talked about the silos that you explained here. And we heard that in Madeleine's silos, it sometimes was enough data to do your work. Is the problem now that we are moving between the silos that is complicating, or what is your thought about that?
First off, let's face the fact. Right now, there are silos. There are national health records, there are locally stored health records at hospitals, clinics. There are wearable devices having their own ecosystems. There are medical devices with their own providers having their own ecosystem. So everything is scattered. This is how it is. Now, yes, there is an issue right now to collect everything and, I don't know, use it to train an AI model and then come up with the next big thing. But down the road, I think that, let's say, the regulatory solutions are coming. But right now, there is still ample opportunity to perhaps focus on smaller chunks. And I don't want to also underestimate some of the opportunities actually provided by new regulations. I think what has gained very little attention right now is something called the Data Act, which it actually will become fully applicable mid-September. So it's in like 2 or 3 weeks. This will actually, it's perhaps more relevant to non-personal data, but it's still data. So imagine you're running a hospital, you have lots of connected devices there. You now gain more control to diagnostic data of those devices rather than this being solely the playground of the manufacturer. And you can, and then I think new companies will emerge, new businesses will emerge to use such data in the wider sense. Yeah, I think, the issue of the silos, this perhaps can already be solved when innovators are using, let's say, smart solutions, employing privacy-enhancing technologies, and overcoming the, let's say, regulatory barriers by that, let's say, or implementing the let's say, technology itself to create the accountability mechanisms or create the trust, the solutions. How can we access data from the silos without actually violating anyone's privacy? So I think this is the way to think right now before we wait for the regulators to solve everything.
Good point. I've been thinking a lot about the word privacy and how we look at privacy. It's really probably one of the most complex things that we are looking at. I mean, a lot of privacy, when you're young, you say, well, could you tell him that I'm interested? And so on. So it's typical there. I was thinking about you, Nasim. If you leave your role now as one of the thinkers of how it could be done, and you're a little bit more realistic, what is your opinion as a medical doctor on how much can you handle without AI?
Oh gosh, very good question. And of course, so I started practicing mid-90s, 1997, my first ever being at stroke unit, so almost 30 years. With that said, I believe what I was thinking was, okay, and human, we make mistakes. We make mistakes. In Swedish, there is, mänskliga faktorn, the human factor. So it happens. And yesterday, Elizabeth shared with us, do you remember the case around her mother? So these things actually happen. So I believe this is beyond my ego as a physician. I know I can be, honestly, I like being the guide. So you mentioned my son, my husband. Another example is my son. He was prematurely born, so he has some kind of lung issue. They say it's asthma, but it isn't. Okay, with that said, we faced a lot of challenges in and out of hospital for him. And it was also when he was around, if you handle children in healthcare or have children with chronic conditions, it's quite sensitive around 10 to 13. He avoided to use his medication because he was kind of, this sets me aside. I don't want to be pointed out that with that boy with asthma. And he ended up in the emergency department. And then the solution to all of this was, when I was first at that first net doctor, Curie was quite new, almost 8 years ago, and he was around 10. So he was given a gadget, a very easy way to measure your lung function. And that's later today that is part of, as a physician in Sweden, you can prescribe it. And so the pricing will be subsidized for every child in Sweden, because we have a lot of knowledge around asthma tuner, Medituner. This is nurses and doctors been studying, so years of knowledge behind. With that said, he was given that device. The thing was that the device talked to an app in his smartphone. And 10-year-olds, they like playing on their phones. And he realized when he used his medicine and he tested this device, the curves were higher and more beautiful. So in order to win and win and win, he learned, yeah, I need to take my medicine. Otherwise, I don't win this game. And one day he just says, Mom, and I take it both in English and Swedish because that brought tears to my eye. He said, Mamma, nu för tiden, jag är kompis med min astma nu. Now I'm friends with my asthma, because he learned, okay, now I'm taking my medicine and it helps me and I'm not getting that bad, so I need to go to the hospital. Now I'm friends with my asthma. That was part of, you see, seeing himself. This is supporting me, finding myself and not being that boy with asthma. So with that said, I believe in the future, or back to my husband's, of course he gathers all the data and then he comes to me, because then we can have a add-on discussion around the nuances and how is it to actually cope his condition as a human being. And there I have years of experience. So I believe in the future, of course, we've been seeing nurses, doctors using all different kinds of AI tools to augment themselves. And I know that it's also, so data could be one piece of information, and many times it's not that valuable. It's when you gather all different kinds of, so it's kind of computing, and we as healthcare professionals, we compute a lot of information in our brains, and that's what LLMs are doing now, much faster. And of course, it saves me time. And of course, many times nowadays, I go more often to PubMed, because I use my co-pilot to, could you digest this paper for me? What are the 3 bullets? So I get smarter, and I can be a much better physician to my patients. So that's a no-brainer. And also, you saw, so Isaac Cohen, you can search for his work. He was quite new. He's a professor at Harvard Medical School University. He's been using LLMs just focusing on rare diseases. It's beautiful, because it's impossible for one doctor to find any kind of, so this has been groundbreaking, helping people or say kids or whatever with rare diseases. So yeah, I see humans and AI.
Good. Superintendent, you have a comment?
Yes, I would like to, because when you said about this, the asthma and how it has helped, I just thought that we have to be really careful so we don't use the data to standardize too much about, but we need to always have room for the personalization. And one thing that we encounter a lot in my line of work is that when you get cancer treatment, a lot of things is messed up in your biosystem, in your body. And for example, patients with type 1 diabetes who use the new AI insulin pumps that are lovely, and they help them with so much, and they give and they reduce the injections and everything, but they have the alarms set on low blood glucose that you cannot turn off. So many of them get sleep problems and sleep interrupted, which causes stress and, stomach problems and a lot of things, because these intelligent AI-driven insulin pumps, they want to make it so secure for the user that the lowest low alarm you cannot turn off. It always goes on with a noise. And this is something that we hear about a lot, and we actually contacted the company, and then they said that, no, but we want to make sure that our patients, customers don't blame us in case they get a low that they cannot get out of by themselves. Whereas the patients say that, okay, sometimes I just take the pen instead and sleep without the pump, and I have to hide the pump in the closet and put stuff on it because it disrupts my sleep so much, and they get actually sick from sleep disruption and are forced or chose to manage the diabetes with the pens, even though they usually don't use pens, but the pump forces them into using the insulin pen. And that's really a way that technology must allow for the user to control it and not be slave under the technology.
That's I love that point, and I see always the problem with.
And I hear in my voice I get a bit angry as well. Yeah.
Yeah, but that the process. I mean, we make devices to follow a process, and we as humans doesn't always like that process, so we take it off and so on. That's the problem. But I would like to connect with you again, Maeden. I loved your story about your son's insights, that suddenly he could relate his asthma when he was playing and so on. And some of your thoughts with Byggr is obviously to connect more and more things together to see something that could happen. So, any thoughts about that?
Yeah,
do you see Byggr as a part of the healthcare?
I actually do. What Nasim said, I fully agree that we need humans and AI. But it's not just like one model that we've been focusing on, the LLMs, but we need different kinds of models. We need more humans, not just healthcare professionals, people in informatics, IT. They all, like you said, speak different languages. We all need to come together in order to solve this. And for example, if some of us know with LLMs is that like us humans, sometimes if we don't have access to the facts, we start making up stuff. It's not lying, it's just that we're trying to fill the gap. So we need some form of model also that is deterministic and has structure and following rules. And then at the end, we need the human to validate this. So I see it more as with Byggr, we're bringing together different people. We have the human in the loop, and then we have the LLMs that are making sense of the data and so on. But also this deterministic point, I think, will be really important for the development and reproducing the outcomes and having the structure and grounding the LLMs. But at the end, the human needs to always validate, and they have the context, the knowledge, and they're just getting empowered. And also the LLMs are getting empowered and grounded. So I think this whole like hybrid approach is something that we would need, not just in healthcare, in different industries, but healthcare, yeah.
I like the word hybrid. It's like to be together with something else. And today it's probably more the else that we are interested in. The time is up, but not really, because I have the approval from Janos to keep on going and going and going. No. But I would like to invite you, dear audience, if you have any questions now you would like to ask to my panel here. It's always hard to ask questions, but the Swedes are coming.
It's on? No? Yeah. Thank you for a very good discussion. Michelle Silvestri, Swedish eHealth Agency. I really enjoyed listening to you, and I heard something from Nasim's keynote, and I have a question to you maybe, and also to the others in the panel about that. And it's about the pilots that you described in your work in Södersjukhuset, Southern Hospital.
Yeah.
So I'm not sure if I got the message really. I mean, you described it as you had something like 85 pilots.
Yes, we conducted,
Yeah.
Yeah.
And you had on the slide that pilots being effective or something like that. So I guess as a medical doctor, you've heard about the diagnosis
pilotitis recurrentis, maybe. Frequent pilot disease, which is mostly described as a problem. For instance, in Sweden, that we have so many pilots, but they never give any final result or final change or improvement. So I would like to hear you elaborate a little bit on that, very briefly, and maybe from the others in the panel, how you see that, and how you get from pilots to scalability, which is really important, I would say. Thank you.
Very good, of course. And Michel, the thing is, the goal was set. We knew that, okay, the way we are working today, this is to be changed. So here is where we are, and we are heading there. So very clear goal. The purpose to these pilots were to get more and more people engaged. For every pilot, 1 week, we had, say, a group of 20, 50 nurses, doctors, and they came from different departments. So not everybody could be part of that. And you know that in parallel with doing this pilot, life is going on. It's kind of, you are on an airplane and you try to change the engines and you are in the air, so kind of tricky. So it was to bring in more and more people into actually experience it before you just push something new to people. Because otherwise, the other way would be, okay, this is the thing today, and it's very much when implementation projects are kind of failing because you haven't been educating or getting people for real involved as part of the process. So the purpose of these pilots were not when it's done, say, okay, done, now we do nothing, back to the old. It was to actually learn, to get people involved, and then use this learning to refine it all the time, to get closer to the goal. That's very important. That's also why you need to stick to the leadership and a lot of communication and being open, also interaction in between the leaders and, of course, the union, because we have the unions too. Doing the risk assessments together with all parties. So I hope this is more clear now. And but the thing is also, and this is global, I thought that was only for us Swedes, not invented here, but I've learned it's everywhere. Yeah. So even though you say, this worked perfectly at Södersjukhuset, you need to do it again at Karolinska or at Erasmus, etc. But it's good for these people to talk to each other. And especially when you are from industry. I never go and but I bring these healthcare professionals together and say, share experiences, but you need to do your own journey, but stick to the goal.
Good. Very good. Thomas.
Yeah, actually, that was exactly what I wanted to pick up, this not invented here syndrome, actually. And then, collaboration. I mean, in Germany, we also have so many pilot projects, but then no mechanism somehow to follow up or to scale up. And often in projects, just the project ends, no implementation follows, and because there is no plan or no money for the implementation, and the implementation is not that exciting, like inventing something. So I think implementation is really hard work. And then I really want to point out this, what I showed, the change management. Yeah. So it's really something, it's more a social, not a technical, but a social skill to bring all the different people together and understand each other and work together. And I think that is often just not cared about. And then sometimes if you introduce a new tool, then when they have a training on this, it's like 1 day crash training, and then the people should just work with the system. Yeah. So it needs more, hearing the users, the people integrate and stuff like that. That is definitely missing.
Very good. Any more thoughts from you guys?
Yeah. I think, I'm back. Sometimes the technology is not the problem. I think we see that it works in different pilots. It's not just the not invented here, but there's also a lot of like political forces that create inertia, like maybe you can help me, lagen om offentlig upphandling, procurement.
Swedish procurement
yeah.
rules, yeah.
For example, to procure a solution would also take another couple years. So we can see that the technology works, it's validated, we've done 20 pilots in 20 regions or municipalities, but to actually implement it is also difficult, and there needs to be like more seamless connection there.
I liked that we now heard that the business model is a problem. We think we as organizations or countries can make the rules on how to do this. Now in the UK we have a big problem with the doctors are using their mobile phones to use Scribe, so they can listen to the patient, have full attention, and they discuss with the patient, and the app is doing a summarization of this and put it into the electronic health record. And it's probably the worst we can do. Or not.
It depends. I mean, and I believe you know that, but I try to educate out of frustration many times, healthcare professionals. For example, I heard one nurse shared with me, Nasim, in the middle of the night, it's intensive care. And I have a patient who speaks Arabic. What do? I need to use a translator. So they try to solve it, but be aware of where the data is, of course. Of course, you don't want to share the data with Meta or whatever. Or I just took a name. So where is the data? So that's why it needs to be protected. Okay, is there any data protection? You were on it too. Okay, now I'm using this device to solving one problem, and then the data is maybe used for another thing. And it wasn't intentional. So that's very important to actually, okay, where is my data? It's important. And the security and safety, very important.
Yeah, it's about also, let's say, for institutions, it's about managing their, let's say, IT resources. What kinds of tools are allowed? What can be used? What are the policies relating to those? Read the fine print. What the terms of service are, what kinds of, let's say, security mechanisms are provided. I think, let's leave privacy aside, but one of the topics that hasn't been covered today too much is this topic of also confidentiality and business secrets. So it's not always question about protection of privacy of patients, but also protecting the confidential data or business secrets of the institution itself, or let's say, let's face it, many players in the sector are there for commercial reasons. So maybe this also fits into the piloting thing that was said earlier, that there is no cooperation. You run the pilot, but you're not talking about it. Maybe the reason is that if you discover something good, you don't want your competitors to know.
Good, interesting. I think I don't take any more questions from the public. I have one last question to you that you will answer just by saying yes or no. And by the end of those things, it's time for some advertisement. And I have invited the Estonian Health Tech Week to Gothenburg in 2029, because we are arranging some world meetings there. So my simple questions to you, in 4 years from now, will we still have a panel that is discussing AI in healthcare? You can start.
Yes.
I agree.
Yes.
We could probably have AI agents to do the discussion.
Both no and yes. So because we will discuss, say, as we just mentioned, different aspects or risks or risk mitigations or ethics not to do this and that. But otherwise, for me, we will be using AI. Of course, we do it today. So then the answer is no. But the house, we can discuss.
Thank you. So we have a reason to meet again. So with that said, thank you very much for your appearance on this panel and your wisdom that you have shared with us. Is it photo time now?
Yes. This is photo time, and as we have actually postponed the start of this session, so we will meet at 12:15 after coffee break. Sessioni.